Hi, Dr. Brian Kaufman. I'm a retired family physician, a CLL patient myself, and I'm the Chief Medical Officer at the CLL Society here in Edinburgh, Scotland for IWCLL.
I'm Anthony Mato, Director of the CLL program at Memorial Sloan Kettering Cancer Center. Happy to be here.
Dr. Mato, venetoclax has revolutionized the treatment of CLL, but there's one significant risk associated with it, tumor lysis syndrome, and you've done some research on why, what risk factors there are. Before we get into that, can you just remind patients what tumor lysis syndrome is and why it's a risk with venetoclax?
Tumor lysis syndrome are the electrolyte and renal abnormalities that are the result of rapid tumor destruction. Essentially releasing intracellular contents. Electrolytes, uric acid, can cause cardiac dysfunction, renal dysfunction, neurological dysfunction. And so when we have therapies that are becoming more and more effective that work almost instantaneously, we're at risk, or patients are at risk for developing this particular complication. It's not something new, it's just been more in the spotlight because of the fact that venetoclax is such an active agent.
Because it kills the cancer so effectively and so fast.
Correct.
That the cancer cells break open
the
and
body
spill out
doesn't
their
have time
contents.
to catch up.
Right, and the kidneys and everything can't handle it. So tell us about what you discovered in terms of how that is a risk for patients and how we can stratify that risk.
This is a collaborative effort from many different centers, and primarily the work was done by one of our fellows, Dr. Lindsay Roker, who couldn't be here to present this. With that being said, we were interested to expand on the current models of TLS risk stratification, which are now based on the label provided by AbbVie and also the FDA, low, medium, and high risk based on the lymphocyte count, based on the lymph node size. You can take that information and estimate what the risk is and then decide whether or not a patient should be in the office, how much fluids they require, what type of agents are required to lower that risk. We've all seen a few patients with low and intermediate risk disease who've potentially gone on to develop electrolyte abnormalities. And so the question that we asked were there additional factors that we could consider that would help us to understand that risk? We performed modeling of 339 patients from 15 academic and 51 community practice sites, and we looked at risk factors. And the one that really stood out the most was creatinine clearance. And we chose a cutoff.
And creatinine clearance is a measure of kidney function.
Correct. How well you're clearing things or filtering things through the blood.
Creatinine's a breakdown product of muscles. Correct. And so when you get your creatinine clearance, when it's functioning well, it's nice and high, It's getting rid of the breakdown products.
It's an estimation of what we call GFR, glomerular filtration rate, which is a way that we calculate or quantify how well the kidney is filtering things. And we chose a cutoff of 80 because that's what's actually defined in the label for venetoclax at this time. And so we included that in modeling, and we found that that was a predictor of TLS in addition to the standard criteria. But we didn't know necessarily if it was an independent predictor, so then we combined them in a model, and we found that not only was creatinine clearance significant, but also the TLS risk stratification as per the label. So they were both independent of one another. And then we calculated an area under something called the ROC curve, which is an estimate of how good that model is. The higher the area, the better the model. We got 75%, which is a modest ability to predict the event. And if you just looked at the standard criteria, it was 65%. So it did seem that creatinine clearance added something to standard risk stratification. And practically speaking, it's something we measure in our patients all the time. We have that readily available. And so it should influence clinical decision making, not necessarily to start venetoclax, but whether it should be done in the office, the hospital, and how aggressive one should be with fluids and hyperuricemic agents for management of that particular outcome.
Yeah. So I want to make sure that venetoclax gets used because it's so effective, but used appropriately and safely in the community. Then not everybody can get to a university setting, so how does that work in the community? And your research is helping the community hematologist understand that.
Thank you for having me.
Thank you so much.
Thanks.
Thanks.